So the initial phase of assessing a patient with a stroke, it includes addressing airway, breathing, and circulation, promptly correcting any factors that are contributing to the patient's condition, and also determining if a patient with ischemic stroke is a candidate for thrombolysis or endovascular surgery. So I'm just going to go into a bit of details for each one. So when you approach a patient, you need to understand that time is of the essence. You basically have just 10 minutes to go through your initial assessment, which would include your ABCs, a quick history, and examination. Important to note that when we say it's quick, it doesn't mean that it's broad. So it's quick, but it's also broad, and all of this needs to be done within 10 minutes, including the bedside investigations that we will go through a bit later on. All right, so with airway, patients with a decreased level of consciousness and those with bulbar dysfunction may have a compromised airway, and patients with raised intracranial pressure secondary to brain hemorrhage may present with vomiting, which can also compromise the airway if it's excessive. Intubation may be necessary in such patients. And then if there is suspicion that a patient fell and might have injured their C-spine, then C-spine immobilization is also important in that case. And then for breathing, increased intracranial pressure due to hemorrhage, vertebrobasilar ischemia, or bihemispheric ischemia can cause a decrease in the respiratory drive. Supplemental oxygen should be given to hypoxic patients for a target oxygen saturation of more than 94%. It is important to note that routine provision of supplemental oxygen in a patient who's not hypoxic is not recommended. When patients are intubated and ventilated, it is recommended that ceftriaxone 2 grams IV be given to reduce the risk of ventilator-associated pneumonia. And then for circulation, we need to put in our 2 IV lines. Preferably normal saline should be given. I will go through fluid management a bit later, as well as blood pressure management, which I'll also go through a bit later. So again, time is of the essence. You only have 10 minutes to get all of this done. So you need to determine the time of symptom onset. This is important as it helps with establishing whether a patient is a candidate for thrombolysis or endovascular thrombectomy. If the time of the symptom onset is unknown, the last time the patient was known to be well or normal is used. For patients presenting within the therapeutic window of intravenous thrombolysis, which is less than 4.5 hours of symptom onset, or mechanical thrombectomy, which is less than 24 hours from symptom onset, the history needs to be accurate but rapid. Contraindications to thrombolytic treatment should also be assessed. All right, so the history and physical examination should be used to distinguish between other disorders in the differential diagnosis of brain ischemia. The presence of acute onset headache and vomiting make the diagnosis of an intracerebral hemorrhage or subarachnoid hemorrhage more likely. An abrupt onset of impaired cerebral function without focal symptoms favors the diagnosis of a subarachnoid hemorrhage. You need to find out, is there a history of seizures? Is the patient diabetic? This could be like a hypoglycemia. Is the patient on any anti-diabetic medication? Is there a history of movement disorder? Is the patient a substance user? Is the patient on any anticoagulants? All right, so going to our examination, firstly, you're going to start with your general examination. So this involves also looking at the skin. Is there any signs of bleeding anyway? Does the patient have any ecchymosis, any petechia? Does the patient have Osler nose Janeway lesions? This way you are thinking infective endocarditis. Does this patient have a new surgical scar? This is talking about now the patient being sedentary or rather less mobile and thus at risk of thrombosis. And then are there any signs of head trauma? Does the patient have any bruise in the neck? Now you're thinking maybe carotid thrombosis. Does the patient have a murmur? Valvulopathies are also a cause of an increased risk of stroke. The pulses, are they regular? Could this patient be having an atrial fibrillation? The lungs, is there equal air entry bilaterally? Is there a stridor? Could this patient have aspirated? And then on the extremities as well, does the patient have cellulitis? Because remember also inflammatory conditions and infective conditions increase the risk of stroke. Does this patient have gangrene? This is now talking to peripheral vascular disease, atherosclerosis. Does this patient have a DVT? This is making you now think of like a paradoxical embolus that could be the cause of this symptoms. Right, and then the neurological examination. The three most predictive examination findings for the diagnosis of acute stroke are facial paresis, arm weakness, and abnormal speech. The acronym FAST is used to help even the lay people be able to quickly pick up a patient who could be suffering a stroke and quickly get them help. It's important that when we see our patients, especially the high-risk patients in our OPD, to just like counsel them on all this on the fast, so that they know that if there's a face droop or arm weakness or speech, time is of the essence. They need to call the ambulance and need to get the patient to the hospital ASAP. I do think that maybe we need to have pamphlets with this FAST acronym being given to each patient who is considered to be high risk in our OPD. All right, I will not go through the stroke syndromes, but it's just important to note that the neurological symptoms or signs that the patient may have could actually point you to where the infarct, or rather the injury, is, as the particular artery that is supplying that particular part of the brain would be then the one that is injured. For instance, in the case of anterior cerebral artery, in those patients, the leg would be more affected than the face. And in the case of a patient with middle cerebral artery injury, the arms would be more affected than the leg. So that is just something to keep in mind, but I won't be going through all of that. So the most widely used and validated scales for quantifying stroke symptoms is the National Institute of Health Stroke Scale. Defined cut points for mild, moderate, and severe stroke are not well established, but the cutoffs of less than 5 can be regarded as mild, 5 to 9 as moderate, and more than or equal to 10 for severe stroke can be used. It is quite a long thing, so I couldn't put it nicely on my notes because I didn't think it would project nicely, but on EM guidance, it is available and you can go through it there. And then just important to note, I think sometimes people can get confused when a patient comes only with some facial asymmetry. Some people will be thinking, is this a stroke? Is this a Bell's palsy? Just important to note that in the case of the Bell's palsy, the entire side of the face would be affected. While if it's a stroke, it would just be the lower side of the face that is affected. All right, so these are the main investigations. So basically the investigations that the patient has to have and should be the first ones to be done. So an urgent brain imaging with CT or MRI is mandatory in all patients with sudden neurological deterioration or acute stroke. All patients with suspected stroke should have the following studies urgently as part of the acute stroke evaluation. So a non-contrast brain CT or brain MRI, what we have access to is the CT brain. So this helps us exclude hemorrhage as a cause of the deficit. It's useful to assess the degree of brain injury and also help identify the vascular lesion responsible for the ischemic deficit. A fingerstick glucose needs to be done as well as oxygen saturation. So before your patient goes for CT, it is enough if ABCs are done, history, that first examination, finger prick glucose and oxygen saturation. If those things are done already, your patient can go for the CT brain. And then just other investigations. So this should not delay uncontrasted CT brain and more definitive management. So an electrocardiogram to pick up any arrhythmias and also to pick up cardiac ischemia, as the sympathetic response to stroke can lead to demand-induced myocardial ischemia. A complete blood count, including platelets, troponin, INR. So thrombolytic therapy for acute ischemic stroke should not be delayed while awaiting the results of hematological studies, unless the patient has received anticoagulants or there is suspicion of a bleeding abnormality or thrombocytopenia. The only test that is mandatory before initiation of intravenous thrombolysis is blood glucose. Syphilis serology in patients younger than 45 without risk factors, a lipid profile, as well as an HIV test. Other investigations as well. So the following laboratory studies may be appropriate in selected patients. So your CUSP, liver function test, toxicology screen, blood alcohol levels, a pregnancy test in women of childbearing potential, an ABG, chest radiograph, as well as urine analysis and blood pressure, blood cultures if fever is present, an LP, as well as an EEG in the case of suspected seizures. All right, so in this CT scan, we are seeing a patient with a subarachnoid hemorrhage. In this case, you would not want to send your patient for thrombolysis. And then in this diagram, we see that the patient has a hypodense area there in the right parietal region that is likely indicative of an ischemic infarct, and this patient could possibly be a candidate for thrombolysis. All right, so there is a thrombolytic checklist. So there's those patients there's an inclusion